Good morning. Yesterday we talked about dialysis and initiation of dialysis. And so today we'll move on to how the different modalities of dialyzing. There's blood dialysis and there's so-called peritoneal dialysis, and there's pluses and minuses to both of them. Let's talk about blood dialysis first, because it's probably more commonly used. And so we'll talk about the different types of blood dialysis, and then we'll go on to peritoneal dialysis, which is a different modality of dialyzing. So if you come to the office and you don't have something ready to use for dialysis, like we talked about the last time, then we have to put these temporary catheters in your chest wall. And these temporary catheters, they're essentially like glorified IVs, I guess you'd say. They work fine. The problem with them is anytime you have something sticking out of you, particularly that's plastic, which these are usually so-called silastic catheters, then you have some potential complications to them. And so, and the potential complications, well, think about it. If you have plastic tubing sticking out of you, where's it going? It's going into one of the main veins that drains towards your heart. And so it's an invitation to getting an infection eventually. Now, I'm not saying that these catheters don't work great, but you don't want them in too long, because the longer you have them in, the higher the risk for infection. So let's deal this video with just these catheters, because it is an important topic. So there's catheters that are so-called tunneled catheters, and there's catheters that are just go directly into the vein. When I was a young guy, and that was a hell of a long time ago, we used to put a lot of these catheters, so-called central lines, for dialysis acutely. That means somebody comes in the emergency room or wherever, they need to start on dialysis immediately. They don't have something available for them in their arm, so we have to put these catheters in. And so I trained that's when I started my general surgery training, 1987 at the University of Minnesota. And I did my fellowship in 92, 93, I think. But anyway, so we would put these catheters in. Typically, the safest way was in the jugular vein, okay? So we used to use anatomic landmarks to do this, which is just so antiquated now, but it was quite a skill back then. So to use the anatomic landmarks, where the sternocleidomastoid muscle, which is the big muscle in your neck here, it separates into two attachments to your clavicle, and there's a little triangle in there. So the anatomic landmark was where the two muscles bellies joined together to form the single muscle belly. You entered there, and you aimed towards the nipple on the same side, and that was just the kind of anatomical landmarks that we used to access it. Nowadays, we use ultrasounds. It's much safer, much more comfortable for patients, because with ultrasound you can actually see the vein and see your needle tip, and so you can really localize it well. So you can do the local anesthesia directly over that area there, get much better anesthesia and much safer way of just accessing that vein. So we would put people in the Trendelenburg position with the head down, legs up, so that all the blood flow would kind of go towards the upper body. That would make the jugular vein swell, and then access these veins. Nowadays we just use ultrasound, and ultrasound just makes it so much easier, because sometimes when people have had catheters for a long time, the vein is scarred up, you can't see it, it goes away, and so you have to go to the other side. So it really makes a lot of sense to use ultrasound. It's the standard of care for vascular access. As far as I'm concerned, it's the standard of care. If you don't use vascular ultrasound for accessing veins in the jugular area there, then I don't think you're really doing the right thing. So jugular vein catheters, we used to just put them directly in there. They go down into the jugular vein, down towards the vena cava, into the vena cava, right above the heart. And that's where you attach it into the skin level here, get a chest x-ray, ready to use. So very quick and easy to use, great. The other position we sometimes used to put them in is in the subclavian vein, which is underneath the collarbone. A little bit riskier. Again, we used to use anatomical landmarks to do this. Just go directly underneath the collarbone here and kind of blindly get into the vein. Having done it a few thousand times, you can do it very safely. The biggest risk is the lung sits right there, and so you don't want to puncture the lung because you get a pneumothorax. Now, that complication should happen less than 1% of the time, but it was a potential problem. So that was the old way of doing it, just direct access into the vein. Nowadays, we have the capability to put these tunnel catheters in, which I think is a much better way of doing it. So the advantage of the tunnel catheter is that it reduces your risk for infection. So the way it's done, kind of the same principle. And this is how you get permacaths, by the way, for chemotherapy or IV stuff. Permacaths are catheters that are underneath the skin that have a reservoir. But it's the same principle. A little Trendelenburg, head down, jugular vein swells up, prep this whole area up with antibiotic stuff, antibacterial stuff, and then under ultrasound guidance, look at the vein and numb up around there, get into the vein, put a wire through the needle. It's called the Selinger technique after the guy who invented it, I guess. So put a needle through the wire through the needle, withdraw the needle. I like to use micropuncture, not always necessary. Micropuncture is a smaller needle, so if you have a potential problem, it's a smaller hole essentially. So micropuncture or just a regular 18 gauge needle, put the wire through the needle, withdraw the needle, because you're in the superior vena cava, making sure it doesn't go down too far because it can irritate the heart. And then numbing medicine to the jugular vein, make a little nick in the skin in your chest wall, tunnel a catheter underneath the skin. These tunnel catheters have a little cuff on them, and the cuff should sit close to the exit site. And you tunnel it up here, and then you put a dilator and sheath, which is exactly what it implies, a dilator with a sheath on it, over the wire, and then take out the dilator and then put the catheter tip through the sheath and position it just above the right side of the heart, the right atrium, and then anchor it in place, sew it in place, make sure there's no kinks in the system. Often do this under fluoroscopy, which is X-ray, continuous X-ray, that, so make sure you're in the right position. Anchor the catheter in here, and then flush it, and it's ready to use for dialysis. Sometimes get a chest X-ray if you don't have good fluoroscopy to make sure it's positioned right, and it's ready to use. So pretty simple technique. Interventional radiologists do it, we do it. Other specialties that have, use a lot of this stuff. Interdimensional nephrologists and my friends who are interventional nephrologists do it. Pretty standard stuff. It works really nicely. And then you can be dialyzed immediately with these catheters. So it's got two prongs sticking out. So that's the principle of dialysis. One is to pull blood out of the system, put it through the kidney machine, clean it up, and then put blood back in. These are staggered catheters. Sometimes there's what's called a split catheters and regular permacaths. Split catheters have a kind of two segments to them like this. And so the one that's further down and the one that's higher up, or they're just kind of joined together, just staggered like this. And so what's the point of that? The point is you don't want to draw and return at the same site because you're just mixing clean blood with dirty blood. So this is what I always ask the surgery residents that rotate with me. Okay, you have one site here and then another site here further down in the heart. Which site do you want to pull from? You want to pull from the one further down or the one higher up? And the answer is you want to pull from the one higher up because you don't want to pull from this, put it through the system, clean it up, and put it back in to the dirty area. So you want to make sure that it doesn't so-called recycle. You want to pull from the top one and return into the clean area because the blood flow is going down this way, right? So you want to, for surgery residents who are watching this, that's a question you may get asked. Pull from the distal end, the lower part, return the distal end, pull from the top part. And so you get a better, circulation. You don't mix dirty blood and clean blood together. But that's permacath placement. It works great. The problem with it is You don't want these catheters in too long. Like I said, they can cause infections. And so, if they get infected, they need to come out. Sometimes you can treat them with antibiotics, but generally speaking, you don't take them out. And I've seen people get really sick with these catheters. I mean, septic sick, where they end up in the ICU. Sometimes these catheters will get infected. They'll seed your heart valves. They'll seed your spine sometimes. I've seen it, all these kind of complications, these catheters. Generally speaking, again, that they really will work well, but you don't want them in too long for those particular reasons. And then the other thing is, it's a piece of plastic tubing that's sticking into a main vein. What's the other potential complications? Well, you can scar the vein up. You can get a clotted jugular vein or subclavian vein if it's put in subclavian. We're trying to avoid the subclavian vein if we can. Jugular vein, generally speaking. So you can clot the vein off, and you'll see patients come in and say, you know what, the catheter's working fine. All of a sudden, they're sort of having severe neck spasms and neck pain. Ultrasound, and you can see jugular vein clot, and then you have to treat them differently. So jugular vein clots, infections, what are the potential problems? And I see this fairly frequently in people who've had lots of catheters. It's what's called SVC syndrome, superior vena cava syndrome. These catheters sometimes can narrow or cause scarring within the veins. And so think of it this way. All this blood flow is trying to go down. If you've got a scarring down here, what's going to happen? Well, it's going to back up on you. And so you'll see SVC syndrome in patients who've had catheters multiple times or have an indwelling catheter currently. So what are the symptoms? Okay, well, if it's backing up on you, you can get facial distension. They get their eyes get really kind of puffy and swollen. The face gets puffy and swollen. Arms may get swelling, and they get short of breath. And think about it. So surgery residents, you see somebody like this, think SVC syndrome. They lie down flat. They get really short of breath. If they lean over, they kind of turn blue and really short of breath. So SVC syndrome depends on the severity of the symptoms. Can sometimes be managed conservatively, but generally speaking, that needs to be addressed fairly quickly because of the swelling issues and stuff. So it's beyond the purview of this discussion to really kind of talk about SVC syndrome. Just, if you're a surgical resident and you see this, recognize it, because it's not recognized very often, I can just tell you. So you see, people who've had catheters in, the face swells, the arms swell, they get this puffiness, they get short of breath, think SVC syndrome. So that's the catheter, and again, they work fine. You just don't want to leave them in too long. That's a blood dialysis. Next time we'll go on to a different type of blood dialysis, the so-called access in the arm. There's fistulas versus grafts. We'll go over the pluses and minuses of all these things. And then what I want to also touch on is, if you're on dialysis, what to look for in your fistula, what to look for in the long run. You are your best advocate. The dialysis patient is his best advocate. That's what I tell my dialysis patients. Look, everybody's really busy. You're the one that matters. So you need to know what to look for, and then bring it to our attention. You can go to dialysis 3 times a week and have a problem, and sometimes it's just not recognized because people are really running around. You're your best advocate. We'll talk about the long-term implications of dialysis access.